We move to next session. Our moderators are Dr. Rupesh Singhal, Dr. Riaz Charania, Dr. Dennis Roziwadia. Our chairpersons are Kapil Veerparia, Dr. Gajendra Dubey, and Dr. Ritesh Shah. Over to chairpersons. You can introduce the speakers, the case, the images, and then we can have the talks in tandem and then do the rebuttal. Over to chairpersons.
Good afternoon, everyone. The first speaker is Dr. Tarun Madan. Tarun sir is expert in not only in coronary, he is expert in peripheral as well as in the structural intervention. He did peripheral plasties in a short time. Then we did coronary plasties. So sir is expert in the peripheral interventions. I learned a lot from him when I was resident in UN Mehta. He is a very good person. The next speaker is Dr. Vishal Gupta. Vishal Gupta is a cardiac surgeon at Epic Hospital, Ahmedabad. He has a experience of the more than 20,000 surgery, and over a period of the 15 years, he is expert in total arterial bypass, beating heart surgery, congenital heart surgery, valve repair, redo surgeries. Over to Dr. Tarun sir for the case.
Thank you, Dr. Kapil, and thank you, Dr. Kamal Sharma, for giving an opportunity to discuss on this case. So, given the case here, I have to speak on endovascular aneurysm repair is the preferred strategy. What is the case being given here is a large suprarenal saccular aneurysm, which is ending above the superior mesenteric artery, the dimensions of which are very huge, 13 centimeter by 11 centimeter. He is a 77-year-old gentleman whose neurological examination is normal. If we go by the guidelines, Endovascular Society for Vascular Surgery and other important guidelines, they suggest endovascular approach rather than open aortic repair for such patients. And though we need to jail the celiac artery or will need to do a fenestrated endovascular repair to save the celiac artery. So here is the case of a saccular aneurysm. So definitely he needs an intervention as early as possible. Risk factors for this case are old age, underlying CAD, probably the history has not been given. He might be having some carotid artery disease also. So minimal invasive intervention is the best way to go. Now let's see what the scoring system says. If we look for a preoperative plan, the mortality risk score scheme for a patient undergoing intervention for abdominal aortic aneurysm, the EVAR edges over the open aortic repair. Suprarenal aortic surgery carries a 4 points, like endovascular carries 0 point. Age-wise also, there are 2 points given for more than 65 years and more than 75 years, 1 point. Now, if we add up the score, the endovascular repair has a lower mortality risk score in comparison to the open aortic repair. So again, if we go for the probability of mortality, endovascular aneurysm repair is a better modality rather than the open aortic repair. Risk of mortality is lower. Suprarenal open aortic repair is a very, very risky procedure, and mortality of the patient increases multifold. Now we look at the comparison of some trials, DREAM trial, Eurostar, EVAR, and OVER. The latest one was carried out in late 2002 and beyond. It all favors that endovascular repair has got a better profile, less mortality, early recovery. Now we look at the aortic zones. If we start from the ascending aorta, our case lands in zone 6 and 7. Zone 6 is where the celiac artery originates, and zone 7 is where the superior mesenteric artery originates. So this is being a saccular aneurysm, means it has a neck which is opposite to the celiac artery ostium, and it is compressing in the vertebral area. But since the patient doesn't have any neurological signs right now, so we'll plan this case for endovascular intervention. What would we do? We put a covered stent in the suprarenal aorta and end the graft at the upper border of the superior mesenteric artery. We pre-cannulate the superior mesenteric artery and celiac artery. If there is a need, we can do a chimney, snorkel, or we can use a branched device also. We deploy the covered stent, we embolize the celiac artery, and if there is a need, we choose to proceed with the chimney to the superior mesenteric artery or fenestrative device. And in the last, we close the femoral groin access with the ProGlide, which is a percutaneous vascular closure system. And if there are financial constraints, we can go ahead with a small arteriotomy in the groin. This is how the fenestrated devices look like. We can see there's a aneurysm stent graft in which the holes have been made and radiological markers have been created. And we can, through these fenestrations, put another covered stent into the branches. So this is another way how the fenestrations or scallops are made. This is how our case would look like. The given picture shows a fusiform aneurysm, but the diagrammatic representation shows a covered stent being deployed in the suprarenal aorta, and there are two chimneys, one to the celiac artery and one to the superior mesenteric artery. In the first part of the picture, we can see the chimneys coming from the sandwich devices, one placed above the celiac artery and one placed across the celiac artery. And in between the two devices, we have two stent grafts which are giving flow to the celiac artery in the SMA artery, superior mesenteric artery. And in the transverse section, the C picture shows how would it look like. Newer generation devices have very improved technology. They have very low profile, that means 18 French to 20 French, very sleek, slender devices. Tip capture mechanism is very nice. They are resheathable. If the device is not appropriately deployed, we can resheath or recapture, and the graft material is very excellent, non-porous. So endo leaks are virtually very less. So this is a diagrammatic presentation of our case. We can see there is a large saccular aneurysm just below the celiac artery and above the superior mesenteric artery. Renals are quite away. We need 1 centimeter of sealing zone, and this is how our covered stent should look like. We embolize the celiac artery, deploy a covered stent. If required, we do a snorkel or chimney to the superior mesenteric artery, and we are good to go. What do the guidelines say? EVAR should be considered a preferred treatment modality in most of the patients. It is reasonable to go for open repair if the patient is younger, because younger patients should not receive the implant because they have a long life expectancy. So what is the advantages in endovascular? No laparotomy, no thoracotomy, minimal blood loss or no blood loss, very quick recovery, low end organ ischemia to the mesenteric vessels. There is no cross clamp in the aorta, fewer respiratory complications because surgery would require intubation and long ventilation. Overall, EVAR edges above the open surgery in the given case. So my plan would be endovascular as the first strategy. Though I do not say that open surgery is not good, we should plan the intervention case to case based. Guidelines are for our guidance. They are not 100% sure that you should follow them judiciously. Final good outcome is what that matters. Thank you. Dr. Vishal Gupta.
Yeah, am I audible?
Yes, yes.
Yeah. Thank you very much, Kamal, for giving me an opportunity to speak. But when I got the topic, I already knew that I am fighting a losing battle. And I thought before I lay down my weapons, patient is a 77-year-old guy with an aneurysm. Everybody will keep coming on me. How can you do an open surgery for such a patient, such an old man with a lot of comorbidities? I knew it was a difficult case to defend, but still would like to try and put my viewpoint. Tarun is an excellent, all said and done, is an excellent interventionalist, doing phenomenal work with his aneurysms. But let us try and make a point for surgeons here, right? So we'll not get into details of aneurysm. Already most of the people know what aneurysms are, and most of these abdominal aneurysms are asymptomatic to begin with, and 70% of the times they are usually detected on an incidental ultrasound for some other pathology. And in case they rupture, and in this patient, as you see, 77-year-old guy with by 9 and 11 into 13 size aneurysm, the incidence and the chances of rupture are very high and carry a very high mortality. If the patients, if they are able to reach hospital, still they carry mortality upwards of 80%, right? So the treatment options, as Tarun also discussed, there are two treatment options: open surgery and endovascular stent grafting surgery. Open surgery would be either a midline approach or a retroperitoneal approach. In a patient who has had a previous surgery, we can go for a retroperitoneal approach so that we can avoid all the adhesions of previous surgery. But we don't know the history of this patient, whether he had any surgery in the past. But retroperitoneal approach That way is a very safe approach because you don't enter the abdomen, you reflect everything medially, and that entire aorta with celiac, superior mesenteric, and renals are in your sight to do any type of surgical procedure. So these are some of the pictures for surgery where we clamp in this patient because the aneurysm is arising at the level of superior mesenteric. In all probability, if we do an open surgery, we will require to clamp at the level of crus of diaphragm. So this is how we expose. And type C, if you can see, this is the aneurysm, especially in this particular patient. It is an aneurysm which is arising at the level of suprarenal. So though endovascular is a fantastic option, if a person of this age would have come to me, the first thing that would have come to my mind would have been an endovascular repair. But it is a complex abdominal aortic aneurysm. It's not a regular routine infrarenal abdominal aortic aneurysm in which endovascular strategies, even I would agree, they are phenomenal. But as Dr. Tarun in his talk said, that in this patient, because the celiac, superior mesenteric, renals are so close by to each other, you will end up either doing a fenestrated EVAR or FEVAR, or you end up putting a chimney or a snorkel to supply blood to the celiac and superior mesenteric. Whereas surgery, though technically challenging, but if centers which are doing such procedures on a routine basis on a retroperitoneal approach in a patient who's otherwise fit, who does not have severe LV dysfunction, or he's not a bad smoker, does not have COPD, surgery would otherwise be an reasonably okay option wherein you replace the aneurysmal aorta with a Dacron graft, and you can either reimplant these arteries or you can put a respective graft to these particular arteries. Or as you can see in the figure B, you can do a Carroll's technique wherein you take out a mound of aorta with superior mesenteric and the celiac and the right renal, and you put it on the grafted aorta, and left renal, of course, if it is going to get replaced with a graft, you put a graft to the left renal. So this is how it would look. The advantage of surgery would be, this is a very old time-tested technique. There is no incidence of late aneurysm formations, as it is to some extent common with endovascular techniques. Once you put in a graft, the only complications that you can see in an open technique over a long period of times are incisional hernias. That transperitoneal approach. With retroperitoneal approach, the incidence of incisional hernia is negligible. Yes, I don't deny surgery have a significant incision. There will be a significant surgical time with patients at a 77-year-old who have a lot of morbidities. So these things, they will come into play. But over a longer period of time, if you look the results, I'll come back at the results of all the trials. Now, what should you offer to this patient? Open surgery or EVAR? I think more than the patient preference, appropriate anatomical criteria are very critical in deciding between an open surgical repair versus endovascular. It's not stressed on his lecture is many times with these patients, you really don't know how much is the neck length, how much is the diameter of the aorta at that level, what is the angulation, because all these things come into play. It's not just, I can understand devices are fantastic, and with all new things coming in the market, it is really becoming technically very simple for an interventionalist to address these problems, and a lot of fantastic options are there, and we subject these patients at our center to endovascular on a very routine basis, and really I'll definitely agree makes the life much easier for such patients. But yes, there are ideal cases that you would need certain amount of length of the neck, the diameter of the aneurysm should be within the limits for that endovascular stent, the angulation should be ideal for placement of the stents. If all these things they fit in, I would definitely agree that stent is a better option. But there are certain complications also associated with endovascular stent placements. But with masters like Tarun, deployment related complications I won't even mention, because with these newer stents, you really don't need to do a cut down in the femorals. All those complications which are related to cut down, like hematoma, lymphocele, all those things can be taken care of and programmed in place. These things are just not heard of. There are some device related, like structural failure and implant related endo leaks, especially in this particular patient who is to end up getting a chimney or a snorkel in the celiac and superior mesenteric, the chances of type 1 endo leak is a possibility in such patients, right? Limb occlusion is definitely not a case. Stent migration sec, these are just to name a few. So get into details of endo leak classification. This is one patient who would, all an endo leak happens in these patients would be a type 1 endo leak. Right? So we just have to weigh the benefits of endovascular over the long term, the risk of device related complications, so survival rate, the cost effectiveness. Most of the talks that I've attended or listened to today, end of the day, it all boils down to the cost, right? When we are living in the era of Ma Yojana, Ayushman Bharat, the moment patient enters and shows you a CT scan of a large aneurysm, definitely, Tarun, I would tell you, the first thing that comes to our mind is also endovascular, that if we can do an endovascular for him, but that would be wonderful. But the moment we open our mouth and utter 6 lakh, 7 lakh, 8 lakh, about, oh my God, this is such a difficult thing. How can we do it? So endovascular is fantastic, but let me tell you that even a nicely done surgery for such patients, long-term results are fantastic.
Absolutely. Absolutely.
We have done is 74, and that patient is still in follow-up with us. It has been 8 years now. They are doing very well. So cost effectiveness, re-interventions, radiation exposure, yes, in expert hands, the amount of radiation I would not say is much. So I would just, again, as you mentioned, there are 4 major trials, EVAR 1, EVAR 2, DREAM, and OVER, which compare endovascular with open surgery. And as you would see in most of the results, you would see the early mortality definitely with surgery, endovascular has less. But when you go over a period of 4 to 8 years, the rate of re-intervention with endovascular group is much higher compared to open surgery. The open surgery, the only re-intervention would be for incisional hernia. Very few incidents of pseudoaneurysm formation at the site of graft implantation. As you can see, the complications for EVAR group is 41 over a period of 6-7 years compared to 9 of open surgery, and the intervention is 20% compared to 6% in patients with open surgery. So in endovascular repair, 50% of the patients at the end of 5-6 years will get into some sort of trouble, whereas 85% patients with open repair will have an unevent-free survivals. So this is again endovascular EVAR 2. This trial mainly compares endovascular with medical management, and aneurysmal related deaths reduced from endovascular, but there is no reduction in all-cause mortality at a later stage in these patients. Similarly, DREAM trial also compares endovascular. Most of the trials, if you would see, they come initial period, definitely endovascular scores over open surgery, but over a long period of time, because of related to the device and the complications, they have a lot of re-interventions at a later stage. So I would conclude by saying the anatomical suitability for EVAR is a proxy for complications and potential aneurysmal related mortalities. The rate of re-intervention continues to increase with time regardless of the device. The compliance with EVAR device guidelines is far too liberal, I would say. It's all related to demand and supply, profiling, industrial interests. So patients with acceptable operative risk and longer life expectancy, though this patient does not fit in that criteria, are still best candidates for open surgery. High-risk patients with marginal anatomical suitability or short life expectancy will not benefit from EVAR, and so on. So I think I would end, as I still said, because we talk of cost, and cost is always a constraint, so we can still offer surgery. This is where, Tarun, we will end up scoring. It is very unfortunate that surgeries like this require an extreme amount of skill and surgical expertise, but just on cost, we lose it against you. It is very unfortunate. Many times, we also feel that it is a good treatment for patients. And if we can get away with endovascular, if the anatomical criteria are perfect and the device is perfect, they definitely score. But yes, you will also end up getting some patients who will not be so affording to get a chimney and a device and a ProGlide, and you may want to send them to surgery. As Dr. Mohit also said in his previous lecture, that this is the surgeon up against the interventional cardiologist, and the device industry, and we are trying somehow to keep ourselves up and about. Thank you very much. Thanks a lot.
Thank you, Dr. Vishal. No doubt surgery is evergreen, and there is no doubt that surgical patencies have been extremely well in the last 40 years, and endovascular reinterventions are very high. Cost is a major issue, planning is a major issue, devices are not hand means readily available. Given a scenario, if this is an impending rupture, immediate surgical results are extremely well, and they are long lasting, but though we should use them judiciously from case to case basis.
Absolutely, totally agree. I am all for
Thank you.
endovascular in a large subset of patients, totally agree with you. But yes, there would still be some cases in which you the technical challenge, and I think there are certain endovasculars like fenestrated. It takes really time for the companies to prepare the graft for you. You check them a CT scan, and based on the images, the distances, the length, they will make a fenestrated endovascular stent for you. All those things that take time. But in an emergent situations, yes, surgery definitely plays a role. Great.
Dr. Kamal bhai.
Yeah, I was thinking, I mean, we had discussed this when we were framing the case, whether to keep a thoracic aneurysm or a abdominal aneurysm, and then we decided to go for abdominal one. Thoracic, then I had framed that we'll keep artery of Eden-Kiewicz coming from it, and then we decided it's a very small branch. And then I think last year Dr. Gajendra was there in that session as well. I think Gajendra was in carotid session last year. But then we thought of that, maybe we will just discuss it out, leave the Eden-Kiewicz aside and discuss a AAA actually, and then take a call as to how to proceed. But I think Dr. Vishal brought out very important concept of the angulation, 60 degrees. I think that's something that is often underanalyzed and probably over-treated as well, I believe. Dr. Tarun, your comments, and over to chair, everyone, Dr. Gajendra, the rest of the chairpersons.
So, good afternoon, everyone, and it was a very informative talk by Dr. Tarun sir and Dr. Vishal sir. I think local expertise also matters a lot in making the decision, because not everyone will be able to do a fenestrated TEVAR. Tarun sir is an expert, but I don't think that such expertise will be available everywhere. So that too should be in consideration, and otherwise, as they have already told about the options, and it was a very nice session by both of them. Thank you.
Last year, I could convince Kamal to keep the age at 50, so that let's keep it a little competitive. But this year, he did not show any mercy.
This year, I had to favor Tarun.
No, but in all, Kamal, I have been listening to the talks. It has been wonderful, and the meeting has been.
I think there is an important person in the team, Dr. Ritesh bhai. He's a cardiac anesthetist, senior cardiac anesthetist. What is your experience about open surgical repair? How many cases do well?
Yeah, surgical repair for these type of individuals actually doing nice. But we have seen your endovascular repair, particularly the patient with 110 kg weight. And endovascular, in that patient, I see a very good result. We have to intubate that patient 110 kg, and you have done endovascular repair. So I think it is more case to case.
Yes, true. So overall, we should get a message that surgery versus endo, we should not favor either of the strategy. Surgeons are definitely our backbone. Without surgeons, cardiology doesn't exist. So any bailout, surgeons are always there to bail us out, and we can't manage everything in cardiology. So we have to understand that. Thank you.
Same holds true for us.
Dr. Rupesh, Dr. Riaz, and Dr. Danish, your comments. Rupesh, you did an anaconda recently.
Yes, sir. A very excellent talk by Dr. Tarun sir and Dr. Vishal sir. Just, all has been mentioned by them. I just wanted to seek sir's comments on what is his, like, if you do a multi-layer flow modulator for such a kind. I mean, we have celiac and SMA is coming, and given that this is a saccular aneurysm, just flow modulation, would it help in this case? Like, how would it compare to other covered stent grafts that are available?
Definitely multi-layer flow modulated MFM stents are available, but the cost of one stent is around 18 lakhs. it's much more than 3 endovascular procedures. They are costing around 4 to 5 lakhs one endovascular. So MFM would cost 18 lakhs. It is much beyond the expectations. Like MFM registries are showing that branches keep on flowing thrombosis over a period of time. I think Dr. Vishal would agree that they did one case on the principles of MFM recently, few months back.
Yeah, you remember that case. Yeah, that was, I think it was an infective etiology, Tarun.
Yeah. Yes.
Because we thought anything we do, maybe that patient was HIV positive and an infective etiology. We were not very sure. So we did this. It's a layered draft. I think 1 or 2 cases have been done. We were joined by Dr. PC Gupta from Hyderabad. And it was a perforated stent. It was basically, it was not a covered stent. And we put 3 layers of stent, one over each, so that it continues to maintain flow into the renals. That patient got subsequently readmitted a couple of times with renal failure, and we had to dialyze him. But in the end, we had to, that patient was taken in the cath lab, and then that stent was perforated in place, and we put a stent in the renal artery at a later stage. Same patient.
I think the basic principle of flow modulation comes from any stent for that matter. Basically, the more number of layers you add, you're going to create more of laminar flow. So even like the coronary aneurysms that we see, when you put a stent across a small aneurysm across, most of the time the laminarity would actually make the side branch aneurysms regress. So it's basically a physics principle of laminating the flow when you actually create a conduit, which is going to create a laminar flow rather than turbulent flow. And the more number of layers that you have in a stent's design, more likely that you'll have more smooth and laminar flow, which is going to regress. So I think the cost, of course, is a big factor, as both of you have mentioned. But I believe with time to come, the technology per se is not extremely innovative. I mean, it's overpriced for the technological innovation that is involved into it. 18 lakhs for that compared to, say, a EVAR of which you can easily get in 3 or 5 or 7 lakhs. So I think the 3 layers shouldn't make it, 3 times the cost, because technology of creating them is pretty much the same. I think it's just adding on a layer to it, beyond, of course, the side branch access and the other parameters that you're talking of.
Thank you.
Great.
Thank you.
Thank you very much. Thank you,
sir.
All right. Thank you, everyone. Thank you, chairpersons. 2 fantastic talks. Thank you, moderators, Dr. Kapil, Dr. Gajendra, Dr. Ritesh, Dr. Rupesh, Dr. Riaz, Dr. Danish.